Hello everyone, I'm Kelly from 1-800.
Hello everyone, Kelly from 800.
Hello everyone,
I'm
Kelly from 1-800 Respect,
and welcome to
today's 1-800 Respect and Women with Disabilities Australia webinar. Before we start, I'd like to pay my respect and acknowledge the traditional owners of the land on which this meeting takes place, and also pay respect to elders both past and present. Today's topic is understanding violence against women with disabilities. We are pleased to welcome our presenters today, Samantha Connor. Samantha is the Policy Manager for Women with Disability Australia. Samantha is a passionate advocate for the rights of women with a disability. She has a lengthy background in disability and human rights, is a board member of People with a Disability Australia, and a member of Women with Disabilities Australia. Samantha has been instrumental in advocating for the rights of people with disabilities to be free from acts of violence, neglect and abuse. Her roles have included membership of the Expert Committee on the Workforce and Sector Capacity Design Group on the National Disability Insurance Scheme, Expert Committee membership on the Stop the Violence Project, and a current role on the Disability Steering Committee for the Royal Commission into Institutional Responses to Child Sexual Abuse. Samantha lives in regional Western Australia, works as a disability consultant and has 6 children, several of whom have disabilities and psychological disabilities. She shares a home with her husband Peter, has 2 dogs named Frank and Lucy, and a cat named Shodinga. The webinar is live and interactive. You're encouraged to participate by posing questions to Samantha, which can be typed into the chat box, which is located at the bottom left-hand side of your screen. There will be approximately 10 minutes during this webinar for question and answer time at the end, and Samantha will attempt to answer as many questions as possible during the webinar. Should your answers not be answered, however, during the webinar, WIDA is very happy to be contacted after the webinar. If you're experiencing difficulty hearing the sound during the webinar, please dial the 1-800 support number listed in the chat box below. I'm now very pleased to pass over to Samantha to begin.
Hey. Hi everyone, thank you so much for joining us and welcome to the webinar. So we are discussing understanding violence against women with disability today, as discussed on the Women with a Disability or a number of disabilities, and I'm currently working for Women with Disabilities Australia. WIDA represents more than 2 million disabled women and girls, and we're a transnational human rights and systemic advocacy organisation that's run for and by women with disabilities. Just so you understand my involvement, I'm working as somebody who has background in disability, violence, abuse and neglect, and I've had some involvement with some of the current things that are going on, including the Senate inquiry that's going on into institutional violence, the Royal Commission and other lobbying activities around prevention of violence, neglect and abuse. So today we're going to go through some background about what disability is, about the human rights approach to disability, what violence is against disability and what we know about violence and disability and contributing factors. We're going to talk about how to address violence against women with disability and also understand some of the barriers that women with disability might experience when seeking help. And we've been asked by 1-800 Respect to actually look at some really practical ways to address those barriers. So we've included inclusive policies and practices, disability access and inclusion plans, accessible information and communication, physical barriers, and organisational attitudes and systemic change. So disability, the way that we understand disability has implications for our responses to women and girls with disabilities who are at risk of or experiencing violence. We used to look at disability in terms of understanding impairment, which was referred to as the medical model, and now we use the social model of disability. So that emphasises that disability isn't just a result of impairment, but it actually results from disabling environmental and social barriers. And international human rights law doesn't actually define disability as such, but describes people with disability as including those who have long-term physical, mental, intellectual or sensory impairments which in interaction with various barriers may hinder their full and effective participation in society on an equal basis. So the human rights approach, our obligations, we're obliged under international law to make sure that our obligations are actually human rights-based responses rather than categorising various disabilities impairments. So that human rights-based approach identifies people with disability as rights holders and subjects of human rights law on an equal basis with other people. It recognises that disability is an element of natural human diversity on the same basis as race or gender. And it places the responsibility on society and governments for making sure that our environment supports the human rights and full inclusion of and participation of people with disability. So the legislation that guides us internationally is the United Nations Convention on the Rights of Persons with Disability, otherwise known as the CRPD, or in the sector sometimes DISCO for the Disability Convention. And we are required to ensure that the human rights of people with disability are recognised and upheld. The CRPD is actually a really useful document. It outlines the rights of people with disability and it uses the social model to explain the obligations of state parties to promote and protect and uphold those rights. So that includes our services that we have in Australia for responding to violence, abuse and neglect. And our obligations are outlined very clearly around our physical location, information, employment, adequate standards of living, support services, assistive technology and lots more. Just looking at women with disability across Australia, I'm a woman with a disability who has a number of disabilities, and that's something that's actually quite important for people to understand is that disability, people can have one type of disability but sometimes up to 10 others, you know, or more. It's one of those things where we're none of us one-dimensional people. We, as women with disability, make up 20% of the population of Australian women. We're very widely represented. We come from a really diverse background, range of backgrounds, lifestyles, cultures and beliefs. And we experience a range of impairments that impact on our lives in different ways. So that can include medical and or health conditions and or sensory, physical, cognitive and psychosocial impairments. And the other important thing to note about women with disability is that we're everywhere. So in a really, really wide array of different settings, including private and family dwellings, institutional settings, residential and service settings, public settings, and we're also very much represented in the homelessness sector. So women with disability are more disadvantaged and we have fewer opportunities than life opportunities. We have lower status and less power than other women and men with disability, and almost half of us in Australia live in poverty. We're subject to the effects of ableism, so the practices and dominances in society that oppress us. We experience multiple and intersecting forms of discrimination that combine to significantly heighten the risk and likelihood of us experiencing all forms of violence. And for those of you who work as frontline workers, you'll certainly understand that those issues of homelessness, comorbidities of perhaps being a person who has one type of disability and then also experiences a psychosocial disability, those kind of issues that we have where we don't particularly fit anywhere quite often present barriers for us. Violence against women with disability doesn't always look like intimate partner violence, which is a lot of lots of times when we're talking about domestic and family violence, that's the way that it's framed. Violence against women with disability is very diverse, and it can sometimes constitute torture or ill treatment, so that includes forced sterilisation and chemical and physical restraint. It's a form of disability discrimination, it's a form of gender-based discrimination, and it often occurs within and as a result of intersectional forms of discrimination. It encompasses gendered disability violence, which is violence directed against a woman because she's a woman, but it's also shaped by the disability context. And this violence affects women with disability disproportionately as individuals and as a group. And as I referred to before, that it can happen in a variety of settings. So relationships and contexts including large residential institutions. In some states, up to 500 or 600 people with disability live in the same setting. Group homes, respite settings, boarding houses, private homes and on the street. And the perpetrators are equally diverse. They can include intimate partners, family members, formal or informal carers, residents, staff and in residential institutions and disability support workers. We experience domestic and family violence in a range of ways. Some of the more unique forms of domestic and family violence include physical violence, and it might look slightly different for women with disabilities. That might involve the withholding of food, water, medication or support services. It might involve misusing medication as a restraint, or using physical restraints, or destroying or withholding disability-related equipment. It might include sexual violence, such as inappropriate touching during caregiving, taking control of reproductive processes, demanding sexual activities. It might include emotional violence, such as verbal abuse, forced isolation, trivialising disability, humiliation, threatening violence, institutionalisation, or the withdrawal of care or threatening to hurt guide dogs, pets or other family members. Financial violence, which includes stealing or taking control, very common, taking control of investments and refusing to pay for essential medication or disability-related equipment, and coercion and manipulation that result from existing hierarchies between people with disability and people without disability. That last area is really important about that power imbalance, which leads to many of those things. During the beginning of this year, we held a Western Australian inquiry into abuse of people with disability. And it was really interesting to note that many of the types of violence that we've just outlined above happened together. So victims weren't just subjected to one type of violence, they were often subjected to multiple forms of violence. We also know that it's more extensive than violence amongst the general population. It's significantly more diverse in nature than women in general. And as a population, women with disability experience very high levels of all forms of violence intensely and frequently. We're typically subjected to violence by a great number of perpetrators, and our experiences of violence typically last over a long period of time and result in severe violence. We have considerably fewer pathways to safety and experience complex barriers to being safe. Another really important issue around our responses to especially domestic and family violence is that women often feel that they can't receive support, or they're physically or in other ways unable to receive that support. 70% of women with disability have been victims of violent sexual encounters at some time in their life. 90% of women with an intellectual disability have been subjected to sexual abuse, with more than 2/3, 68%, having been sexually assaulted before they turn 18. And these statistics are just quite astounding. You know that we recognise that the number of people with the number of women with intellectual disability who have been abused. This is reflective of why we have a current Senate inquiry and also the Royal Commission. The rates of sexual victimisation for women with disability range from 4 to 10 times higher than for other women, and women with disability are 40% more likely to be the victims of domestic violence than women without disability. Just noticing a question from Jan, which is relevant, so I won't leave it till the end. So Jan, statistics, you can have a look on the Women with Disability Australia website, and there's a couple of fact sheets as well that actually reference where all of those statistics are from. And yeah, there's multiple submissions and information on that website, and we've got the link on the last page of the slide. So we also know that 1/4 of all women with intellectual disability will be subject at some time in their life to some form of restraint and or seclusion. Women with disability in residential institutional and service settings frequently experience sustained and multiple episodes of violence, particularly sexual violence. And that can include co-resident abuse rather than just abuse by other perpetrators who may include staff. There's also the issue of forced contraception through the use of menstrual suppressant drugs. It's a really widespread practice, particularly affecting women with intellectual and or cognitive impairment. It's not really uncommon for women to all be going and getting a Depo-Provera shot every month in the group home. The issues around menstrual management and paucity of support. Women with and girls with disability in Australia continue to be at risk of experience forced sterilisation, which is recognised globally as a form of torture. And that theme around lack of support is something that is absolutely related to forced sterilisation. There's numerous examples of prepubescent and adolescent girls who have experienced forced sterilisation in court. And there's a lot of submissions that have gone into the Senate inquiry a few years ago about forced sterilisation. Some of the more alarming comments in court were around, the fact that this person might develop a phobia about blood, that the person may experience menstrual cramps and that would be a bad thing, that the caregiver, the person only received unpaid care and therefore it would be overly burdensome for the parent or carer to be having to provide that support for the young woman with disability. So the other contributing factors that women with disability themselves have identified about pervasive and extensive violence include that place of residence or service setting, dependence on others, fear of disclosure, perceived lack of credibility or normalisation of violence in institutional settings. And we see that quite often where there's violence that's reduced to administrative error and nobody was ever accountable. Lack of access to the criminal justice system, poverty and lack of economic independence, exclusion from the labour market. Many of us don't have jobs or are unable to get employment. Lack of awareness and knowledge of rights. Lack of awareness and knowledge of what constitutes violence, which is really important. A lack of access to crisis accommodation and support. A poor understanding by service providers of the complex nature and multiple forms of violence against women with disability. And also a lack of participation in and access to decision making. This is a case study from a woman who's a 39-year-old woman with an intellectual disability. She was and is recently raped and bashed 3 times in 1 week by several different men. She lives in a semi-supported residential facility. In one of the attacks in the local park in broad daylight, she was repeatedly anally and vaginally raped and beaten. When she made it back to the residential facility, a staff member made her hand wash her bloody garments. The worker wrongly assumed that Christine was menstruating, despite her being on an injectable contraceptive, and she was reprimanded for getting blood on her clothes. 2 days later, Christine disclosed the rapes to her friend, who helped her report the rapes to the police. The police initially assumed that Christine might be making it up. Forensic evidence established clear evidence that the rapes occurred, but the detectives decided not to investigate because Christine has an intellectual disability. And I'd just like to add to that, aside from this case study, there's many examples of the 51 interviews that we did in Western Australia at the beginning of this year. There was not one perpetrator who was actually taken to court. So there were clear barriers from the time that a person experienced violence, neglect, or abuse, all the way through to where somebody shouldn't have fought. You can look and see where all of those barriers took place. The theme of assuming that people might be making it up and not being believed is a really common theme. So in order to address violence, interventions and prevention strategies are contingent on how we understand violence against women with disability and how we define it. So we need to have a really inclusive and comprehensive conceptual understanding of violence. And that includes that full variety of violent acts experienced by women with disability in the full ranges of settings and relationships they experience. Rape is rape. It doesn't matter if you're raped in a group home or institution or if you're raped on the street. You should be able to access the same services and supports as women without disability have. We also really need to understand intersectionality and experience with violence. The types of barriers that to seeking assistance that women with disability might experience when seeking help. They might not be aware that services are available to them. Many women don't know that refuges exist, especially if they're in isolated and segregated settings. Information about domestic violence and family violence services might not be freely available to them where they're living, or it might be actively denied to them by the perpetrator of violence, especially if it's a caregiver. And it also might not be available in the correct format, and that includes Braille and Auslan, but also easy English for women with intellectual disability. Inappropriate or inadequate education can mean that women with disability are unaware of their rights, and there's not really much education that's tailored for women with disability about rights, but also about what violence looks like, what respectful relationships look like, and that level of education for women with disability themselves. Women with disability are frequently not believed upon disclosure, and services that are often not accessible because of attitudinal, information or physical access barriers. There's an interesting thing in the disability sector that people believe that there are special things for special people always. And so in case of being able to access main support, there are no specific violence supports, for in many states. And so people with disability are often denied access to help because of that lack of So women with disabilities and support services like disability services and police may believe that crisis accommodation or refuges may be inaccessible, and that might not be the case, but people might believe that that's the case, and also unable to provide them with enough personal support. They might rely on their abuser for daily personal care, which places them in completely unequal power relationships. And they may also feel that accessing domestic and family violence services may result in them being institutionalised. That's a really real fear, that young people in nursing homes in Australia is not a thing of the past. So if you're in if you don't have funding for care and support, and you might be prepared to actually put up with being abused rather than go and seek help. Women with disability may also be segregated physically in residential institutions or disability-specific services, or socially segregated due to discrimination and prejudice. Being isolated physically or socially also means that a lack of supportive informal networks. And I know for many women without disability, those supportive networks are actually the ways that people quite often access support. So looking at the practical side of how to address those barriers, having inclusive policy procedures is, we quite often face discrimination when we're trying to gain access to services, including domestic and family violence refuges. And so services really have to be aware of and implement an intersectional understanding of domestic and violence in domestic and family violence in their policies. So gender is not the only dynamic in terms of intersectionality. A friend who escaped domestic violence was saying that as a deaf Aboriginal lesbian who lives in a regional area, there was nothing that fit her in terms of her being supported to access help and support. An intersectional approach requires access and accommodation, programs and support targeted to women with disability. And quite often we overlook the needs of women with psychosocial disability, especially when they don't identify with having mental illness. Quite often those women are identified as being troublesome people, and it really is an area where, especially when there are comorbidities, that people need some extra attention. Staff have to be trained in recognising trauma responses by women who are displaying a range of coping strategies, and they may not look like the same types of trauma responses that women without disability have, especially if the woman has an intellectual disability. And agencies also must address professional development for staff and develop partnerships with disability and mental health organisations if that service doesn't have the expertise. You don't need to do it all by yourself. Disability access and inclusion plans, I've said and inclusion plans because I'm from WA, where they're mandated by law for public authorities. In other states of Australia, disability action plans are quite common, and they're very useful documents to be able to identify and address any other barriers that are hindering people from using the service. The Disability Discrimination Act in 1992 says that it's unlawful to discriminate against people with disability on the basis of their disability. So this really isn't a nice add-on thing that people can do. This is actually something that's required under law, and that includes access to information, physical premises and employment. So we have an obligation to develop inclusive policies, procedures and practices and review and implement them and review them regularly. But there's no single change that will make your service accessible. So it's not going to be a silver bullet with putting an accessible toilet in or a ramp. You need to have flexible changes, and it's also really important to consult with women with disabilities to understand the types of changes that might make your service more accessible. Accessible information and communication is often highlighted as one of the key issues for women with disability. You know, your informative materials, it's a great idea to look at how accessible they are, but also how widely available they are and whereabouts you're distributing them. So that might include disability services, it might include doctors' offices, advocacy organisations, schools, community centres, accessible bathrooms. Your website should be accessible, and you should meet the web content accessibility guidelines, otherwise known as the WCAG, which is the easier acronym. And you should also have accessible documents if they're downloadable documents. If it's a poster, make sure it has an accessible text description. If you have a downloadable area, then please make sure that your documents are in Word rather than PDF or accessible PDF, and have easy to read content. Easy English is often overlooked. Given the number of women with intellectual disability who are abused, it makes sense that we would have easy English documents available for those women. They should also be available in Braille, large print, audio and electronic. During the intake, you should ascertain the accessibility and communication needs of women with assistance. And so some women with intellectual disability might have difficulty remembering information. So giving people the time to absorb information and maybe breaking up induction sessions into parts so that you can communicate that information really clearly and giving people enough time. All of those same sort of principles that you use around reflective listening for women from non-English speaking backgrounds are the same kind of thing. You need to make sure that people have understood what you're telling them. And providing information and rules in writing and in accessible format. So thinking about perhaps an informative DVD, giving people a hard copy in easy English so they can refer back to it later might also help. Some people might also need support to understand material, and they should be able to access that disability care and support. For women who are deaf and hearing impaired, Auslan and other interpreters should be made available. There was a very interesting police case raised a few months ago about the police force who asked the abuser, who was the caregiver of the person who was living with a deaf woman, who was asked to be her interpreter because the police didn't want to pay for an interpreter. So asking your abuser to say what had happened is just the most odd circumstance that you just couldn't imagine anywhere else. And that's something that's quite common in the disability sector, that people in hospitals are unable to access interpreters past 5 o'clock. There's really huge issues around resourcing and access, and organisations should really plan to make sure that that they are adequately resourced to support those women. The other thing around Auslan interpreters is that small cultural and linguistic communities actually have, there's confidentiality issues where people speak amongst themselves. And so for some women, they may prefer to use their own interpreter and, to avoid making sure that there's no breaches of confidentiality. Physical barriers as a wheelchair user, this is always my pet thing, but it's not just about a ramp, there's lots of physical barriers. So carrying out an access audit and asking people with disability about the accessibility of your service is a great idea. There are lots and lots of access tools you can employ. If you're a bigger organisation, you can employ an access auditor. There are places like AAA who will recommend people in your state. You can ask people with disabilities about the accessibility of your service, which is a really easy way to do that. There's also checklists that you can download from the internet, which are freely available, so that you can just look at, your continuous path of access from the car park all the way through to your service, and whether your reception counter is the right height, and all of those physical issues. And some changes might be small things. So they might be organisational practice issues, and some might be major changes. So putting in an accessible bathroom, which is never a cheap exercise, but is required by law. You need to think about other easy changes, like having adequate storage, making sure that rooms have enough lighting and seating, installing handrails, making sure that women who use the service are aware of accessibility of areas. So for blind women and vision impaired women, not drastically rearranging the furniture and making sure that you put items back into cupboards are probably important things for people who are already disorientated because they've gone through a traumatic experience, and they then need to orient themselves to somewhere new. It might take people to get a while to get used to the physical environment. And the last thing is the organisational attitudes and systemic change. The attitudes of service staff, managers and governance bodies can also be barriers to women with disability. And in the inquiry that we did at the beginning of the year, it was really interesting to see how people had the perception that women with disability could be treated differently. Women who were raped and where there was evidence of rape and pregnancy, in institutions, it was reduced to administrative error and dealt with internally rather than being taken to external bodies. There's also issues around attitudinal barriers that are based on stereotypes and myths that are really deeply entrenched. People may think that women with intellectual disabilities, for example, cannot be sexual beings, that they'll be forever childlike. That women with disabilities can't be sexual beings. There's, issues around the way that people are perceived really actually informs the way that we respond to people. We should be increasing staff awareness and participating in disability training. There is good and bad disability training of all types, as anything else, and asking it to be human rights oriented training is always a good idea. Engaging staff and encouraging staff to engage with your disability action plan is a great idea, rather than having that one person in the organisation who is responsible for carrying it out. Making sure that there is whole of organisation carriage of that disability action plan, and that it's embedded in your operational plans across your organisation is a great idea. And so, for example, with your accessible information, that if you're a big enough organisation who has marketing staff, you really need to make sure that your marketing staff understand the requirements under the DDA and what they're part of carrying out the disability access and inclusion plan is to be. We should be illustrating the intersectional experience of domestic and family violence, and also collecting data which helps inform your future practice with a focus on the extent and prevalence, the forms and nature of the violence, and causes, consequences and effects. I did notice previously that there was a comment about data and where some statistics are from, and I would like to make the comment that there's actually a really limited amount of data because of the lack of collection of data in a range of different circumstances. And that's something that we really need to start doing properly. We do have the Disability Abuse and Neglect Hotline. The information that comes out of that goes directly to government and isn't publicly available. And there's not really any way that we collect data systemically across Australia. And so that brings us to our question time. And we've just got a little piece on the end just to recognise that we do have Article 6 of the Convention of the Rights of Persons with Disability that says that we have to do this. We have to take measures to ensure the full and equal enjoyment of women and girls with disability of all their human rights and fundamental freedoms. Okay, thank you. So, Kelly.
Wonderful, Samantha. Thank you so much. And we will head straight over to questions now. We have a question from Katrina who's asking, does any consultation occur regarding the forced contraception? Who is forcing it? Doctors, GPs, etc., or is it family members making the decision on behalf of the woman?
There's a whole number of submissions and information on the WIDA website. I think it really comes from a variety of perspectives, and some of it is, you know, when family members are absolutely involved in going to courts to try and access forced sterilisation. A lot of the myths and stereotypes about the sexuality of women with disabilities is instrumental in informing those decisions, I think. You know, the myth that women with intellectual disability will be perpetually childlike, that they'll never have a relationship, that they could never actually have children, that they never would be supported to have a family, those sort of issues. I certainly know many women with, older women with physical disabilities who were sterilised in institutional settings when they were younger women and girls, and I think that's rarer now. It's certainly not rare for women and children with intellectual disabilities. So if I can refer you back to that last slide, there's the WIDA website link on there, and if you just type into the search box forced sterilisation, there will be way too much information.
Fantastic. We have another question, Samantha. Cheryl asks, are efforts being made to look into alternative ways of ensuring carers, residentially and institutionally, are thoroughly checked, criminal and medical past and present? Is it possible for carers to have regular supervision and debriefing in an endeavour to prevent possible issues coming to fruition?
Cheryl, you just hit on my pet hobby horse, so I'll try not to go on and on and on. So in each state there are different schemes. So in Victoria we have things like the Victoria Workers Blacklist, and we also have vulnerable persons cards in other states. There are blue cards and there are yellow cards, and there are working with children's checks, and there is no harmonisation of any of these things. So absolutely this is an issue, and this is something that has come up and is being currently discussed in relation with the NDIS safeguard paper and also with the Senate inquiry. So there's issues around not only harmonisation and how this will fit into each state laws and violence responses, but there's also issues around making sure that people are still able to have choice and control around selecting their own worker, etc., if they're self-directing their funding. So very, very big and complicated issue and work. I think the safeguarding work that is being carried out at the moment has been informed by mostly the disability service sector, not necessarily by people with disability themselves. And I think the stories of people with disability really needs to be you know, taken into account to look at the efficacy of some of the things that they're coming up with. I don't know whether I've answered your question, but I'm certainly happy to give you more information inform of some of the work that we've done over the course of the last 2 years about that.
Great. Elizabeth is asking, regarding the Family Violence Index, will WIDA be advising the Victorian Government to ensure that data on women with disabilities and violence will be captured adequately?
Yep, so so that's a very good question. Women with Disabilities Victoria would probably be more engaged with that process, I would say. But there's a lot of state and federal action happening at the moment. I'm aware that the national plan on the elimination of violence against women and girls is currently happening, and would have certainly been a part of that. I would really be happy to take that to the table if you had some further information, Elizabeth, because I think that that's a really, really important point about making sure that data is captured properly.
Right. Samantha, Melanie asks, are there examples of good, respectful relationships training here or internationally, or any programs already running that could be adapted?
I'd have to declare my interest as a board member of People with Disability Australia before I answer that. So I'm only aware of the fact that People with Disability Australia do carry out accredited human rights training around that specifically. So they run a segment specifically on respectful relationships training for people with disability. I'm also aware that a lot of service providers, especially the bigger ones, have actually, developed their own training, and there is absolutely some international training that's being carried out. We developed some fact sheets earlier this year about for women with intellectual disability in easy English about recognising the types of violence, abuse and neglect which are perpetrated against women with disability. And those kind of resources, I think, are fairly freely available in different states. I think Victoria has put out some equivalent documents.
Great. We have a question here from Delia, Samantha, who asks, what recent successes would you like to talk about that WIDA has achieved?
Oh, apart from the international successes, because there's Women with Disability Australia are very well known internationally for their work with the United Nations, and I think the focus that Women with Disability Australia have on disadvantage and disadvantaged populations, and especially the work that they've done around supporting the rights of women with intellectual disability, has been quite key consistently over the last 18 years or so, really. So when you consider the size of the organisation and what they've managed to achieve in that time, it's quite astounding, really, on barely any money. So yeah, so it's probably a good idea to have a look at the WIDA website. I don't know how well Carolyn records her successes, but they've certainly made some major inroads in making sure that those things that we take for granted are underlined with a disability focus for almost everything.
Well, Samantha, I think that's a good one, a good question to wrap up with now. And I'd like to thank you very much for your presentation today, and as well as thank everyone for attending today's webinar. A special thank you to everyone that submitted questions, and I know that there are a lot of questions that came through, and if you missed out on having your question answered, please contact WIDA directly. Finally, I'd really like to take this opportunity to bring your attention to our next very exciting webinar on Thursday, the 22nd of October, with Jennifer Burns. Jennifer's the Director of Anti-Slavery Australia and Associate Professor of UTS Faculty of Law. Jennifer will discuss trends in Australia, laws against forced marriage, terminology, warning signs and indicators, impact on survivors, as well as support services available. You can find out more by visiting 1800respect.org.au. And additionally, we'd also like to encourage you to share Daisy. It's an innovative new app, or innovative app that's been recently updated that connects women to support services. For more information about Daisy, again, visit the website. Now, please stay logged in to take our online survey, which you'll be redirected to very shortly. And thank you again in advance for your participation, your questions and your feedback. And we wish you a very good afternoon. Thank you.